Thanks so much, Pat, and thanks for the invitation to come and speak to this audience. As Pat said, I've been charged with giving an overview of the Children's Oncology Group's approach to the treatment of neuroblastoma. And I'll pick up where Dr. Cohn left off with really three areas of focus. The first will be on patients with intermediate risk disease, and then we'll spend the majority of our time talking about patients with high-risk disease and COGI's approach to treatment of high-risk disease. And we'll end with a few slides on the COGI's approach to patients with relapsed neuroblastoma. So first, intermediate risk disease. Really, from a very big picture perspective, the COJI approach to treating patients with intermediate risk neuroblastoma is to maintain the very high cure rates that Dr. Cohn showed with limited long-term and limited acute toxicity of the treatment. So really, the strategy that's been utilized is to use what we know about the tumor biology and also an individual patient's response to initial chemotherapy to try to tailor treatment for each individual patient. So this is a little more detail about one of the protocols that Dr. Cohn mentioned, protocol A3961. This was a clinical trial that treated 479 patients with intermediate risk neuroblastoma. Patients who had favorable tumor biology received 4 cycles of modest outpatient chemotherapy and also surgical resection of the primary tumor. Patients who had unfavorable biologic features but still were considered to have intermediate risk disease, or patients who initially received 4 cycles of chemotherapy but had an incomplete response to chemotherapy, received a total of 8 cycles of the same modest intensity outpatient chemotherapy and also surgical resection of the primary tumor. And both groups of patients had survival rates over 90% with little long-term late side effects. So the successor clinical trial was called ANBL 0531, and this uses the same strategy with some refinements based on what we learned in A3961 and based on new understanding of tumor biology. So some of those refinements are shown here. First, we further refined our definition of favorable and unfavorable tumor biology using a specific genetic change in the tumor called chromosome 1p or 11q genetic change. And then in addition, for a select group of patients with favorable biology, we attempted to reduce the number of chemotherapy cycles to just 2 courses to see if we could maintain very high cure rates, but expose those children to even less chemotherapy and therefore less risk of late side effects. In addition, in the previous study, A3961, the goal was to treat with chemotherapy and surgery until there was either a complete remission or an almost complete remission. And now in protocol ANBL 0531, for some patients, we believe that they can be treated with up until achieving only a partial response and then being followed closely. Again, understanding that these patients have an excellent outcome and trying to spare them some of the long-term side effects of chemotherapy. So this study has very recently completed enrollment, and we're anxiously awaiting the results of these refinements to see if we've met our goal of maintaining high cure rates with limited toxicity. And what that means is that we don't currently have an open COJI study for a patient with newly diagnosed intermediate risk neuroblastoma, and we're actively planning a successor study, perhaps in collaboration with our European colleagues. So we'll move now to our approach for patients with high-risk disease. And this schematic shows our overall approach to patients with high-risk neuroblastoma. We start with an induction phase. We move on to a consolidation phase, and then end with treatment of minimal residual disease, and then observe off treatment. And we'll now dive into each of these phases of therapy in more detail. So what are the goals of induction therapy? Really, the ultimate goal is to get the disease into remission. We can't cure this high-risk disease if it doesn't go into remission. So that is really the goal of induction therapy. There are a couple of other important steps that also take place during the induction phase of therapy. One is to harvest stem cells from the peripheral blood to store for later transplant or for other later therapy in the event of possible relapse. In addition, another important goal of induction chemotherapy in the induction phase is to have some time to remove the primary tumor surgically. So this schema shows the current standard induction therapy that's used in high-risk neuroblastoma trials in the children's oncology group. And the names of the specific drugs aren't so important. What's important to know is that in our trials, patients receive 2 courses of initial chemotherapy and then typically undergo stem cell harvest and then receive 3 more cycles of chemotherapy, then typically undergo surgical resection of the primary tumor, and then receive a 6th cycle of chemotherapy before moving on to the next phase of therapy. And this, while the names of these drugs are not so critically important, what is important to know is that this type of chemotherapy is very different from the chemotherapy used to treat intermediate risk disease. Because we know these patients have higher risk disease, we need to use more intensive, more aggressive chemotherapy. So this is intensive chemotherapy. It's typically given in the hospital. Patients have a fair bit of acute toxicity, including very low blood counts, need for intensive transfusion support with platelet and red cell transfusion support, and also a fairly high risk of developing significant painful mouth sores that may require them to come back into the hospital and may require them to have to need nutritional support to help support them through this very intensive phase of the therapy. So once a patient completes induction chemotherapy, they then move on to consolidation therapy. And the goal of consolidation therapy is really to consolidate or secure the remission obtained during induction chemotherapy. And the mainstay of consolidation therapy is what we call transplant. And really what transplant is, it's not so much a transplant from another person, it's using stem cells from the patient themselves to help support recovery after using higher doses of chemotherapy than the patient could tolerate without that stem cell support. So really, we call it transplant, but the more proper wording for it is high-dose chemotherapy and stem cell support or stem cell rescue. But for short, we call it transplant. So what we know from the literature and from past work is that we have 3 previous randomized trials that have all demonstrated a significant improvement in outcome when we use high-dose chemotherapy and stem cell rescue. I'll just talk about one of the protocols here, and that was COJI's protocol. This was a study called 3891, and this study treated 379 patients who were randomized to either transplant or to ongoing standard chemotherapy. So half of the patients received transplant and half of the patients received chemotherapy. So the results of this study showed that 66% of patients who were randomized to transplant had a relapse or another significant event, And more patients, 78% of patients who are randomized to receive ongoing chemotherapy had relapse or other significant event. And so what this study showed, as did 2 other studies, showed that with the use of high-dose chemotherapy and stem cell rescue, that the number of patients with a relapse or other significant event was reduced with the use of transplant. So with these results, the use of transplant really became standard of care in patients treated at COJI centers. With the success of this study, 3891, and also the other randomized trials showing the benefit of transplant, several hospitals attempted to give double, or what's called tandem transplants, back-to-back, usually about 6 weeks apart. And the thinking here is if 1 is good, 2 is better. And some people have done triple transplants. If 2 is good, 3 is better. So it's harder to draw firm conclusions from these smaller studies because they're smaller studies and fewer patients have been treated with these strategies. But these smaller studies have suggested that 2 transplants might be more effective than just 1. So this is just one example of one of these smaller double transplant studies. In this study, patients had their induction chemotherapy. The sequence and the chemo is a little different from what we're using now in the children's oncology group, but they had an induction phase, and then this shows their consolidation phase, where they received 1 transplant here, with drugs called carboplatin, etoposide, and cyclophosphamide, and then had stem cell support to help them recover from that first transplant. And then about 6 weeks later, had a drug called melphalan and total body radiation, and then received another boost of stem cells to help them recover from that, and then completed the consolidation phase. And in this one small study done at the Children's Hospital of Philadelphia and at Boston Children's Hospital, only 42% of patients had a relapse or other significant event. So this was suggestive that perhaps doing 2 transplants might be better than 1. So this led to our current open COJI trial for patients with high-risk neuroblastoma called ANBL-0532. And in this study, patients complete the induction chemotherapy that I showed you on a previous slide, and then they are randomized either to receive what we consider our standard transplant regimen, which is carboplatin, etoposide, and melphalan, called CEM transplant, or a tandem transplant where they receive a drug called thiotepa with cyclophosphamide, and then 6 weeks later receive a second transplant the same as they would have gotten on the single arm CEM transplant. And then all patients, as part of their consolidation therapy, receive radiation to the site of the primary tumor and also to any residual metastatic sites that might still be active prior to the transplant. So this is our ongoing study that is open at COJI centers, at I think almost all COJI centers. So recently we've learned of some results from Europe where the European equivalent of COJI conducted a randomized study that compared CEM transplant, which I'll call the COJI style transplant, which we believe is our standard, to what's called a BU-MEL transplant, a European style transplant. And these are just the names of the drugs that are used as part of the bone marrow transplant. They're chemotherapy drugs, and the goal of the study was to try to figure out if using this type of chemotherapy was better than using this type of chemotherapy, and also to understand the toxicities of these 2 different approaches for transplant. And what we've learned recently is that this study showed that patients who were randomized to receive the BU-MEL type of transplant had fewer relapses or other significant events. In terms of toxicity, we saw that patients who received the CEM or COJI-style transplant had more mouth sores and higher rates of hearing loss because of the drug carboplatin that's part of CEM. However, we noted that there was a higher risk of liver toxicity that can be potentially life-threatening with the use of the Bumel style transplant. So we've been getting a lot of questions about, well, what do these new results mean for a patient in North America or enrolling on a COJI study where we consider CEM to be the standard? So we've looked very closely at this question to try to figure out what the best approach should be for our patients on COJI trials. And when we looked at all of the data, we noticed that patients who were treated with Bumel had a very similar survival from the European study to what we see when we treat our patients on COJI protocols with CEM. So the better arm of the European study looks to be equivalent or very similar to what we see in the COJI when we use what we consider our best transplant regimen. And we've been thinking long and hard about why that might be, and we think that part of this may be due to the fact that the induction chemotherapy drugs that are used in Europe are very different from the drugs that are used in the children's oncology group. And in particular, patients in Europe receive a lot of the drug carboplatin as part of induction, whereas in the COJI, we don't use carboplatin at all as part of induction. And so it may be that those patients in Europe who received CEM had already had so much carboplatin that their tumors were resistant to it, and that there was no additional benefit from them receiving more carboplatin as part of their transplant. And so for those patients, using two new drugs, busulfan and melphalan, or Bumel, may have been more important. Whereas in the COJI, our patients have never been exposed to carboplatin, and we would expect that they would still be sensitive to that very important drug. So as of now, it's unclear if a Bumel or European-style transplant will be better if used following COJI induction-type chemotherapy. And we still feel it's very important to determine whether two transplants are better than one transplant. And as a result, our randomized trial that I showed will continue, and our CEM COJI-style transplant remains our standard approach. So that's our current study. Where are we going with consolidation in the children's oncology group? So we've heard a little bit about MIBG, and I'll talk a bit more about that. Now, is we think that this will play an important role in our consolidation plans in the children's oncology group moving forward. So MIBG is a drug that is specifically taken up by neuroblastoma tumor cells. And we know that if we tag MIBG with a low dose of radiation, we can use it to do scans to look throughout the body for neuroblastoma. I'm guessing most of your children have had MIBG scans. Well, several decades ago, we learned that we could give MIBG at much higher doses as a way to deliver radiation to sites of neuroblastoma throughout the body, and not just do scans, but deliver high enough doses of radiation that we could provide a form of targeted radiation therapy to try to kill those neuroblastoma sites instead of just taking pictures of them, trying to kill those sites. And what we've learned over the past several decades is that high-dose MIBG therapy is one of the most active treatments we have for patients with either relapsed neuroblastoma or for neuroblastoma that is refractory, that hasn't responded well to initial chemotherapy. So with those very promising results, our more recent studies for patients with relapsed or refractory neuroblastoma have been trying to combine MIBG therapy with other drugs that we think might make the MIBG more effective. And one of our first attempts at doing this combined high-dose MIBG therapy together with a chemotherapy drug called Irinotecan, which makes tumor cells more sensitive to the effects of radiation. And really the goal of this was to try to improve the response rates of MIBG by combining it with other drugs. So this is 3 MIBG scans on a patient treated on this trial at 3 different time points. So this is when the patient entered the trial. And when you look at these MIBG scans, there's a few normal parts of the body that take up MIBG. One is the bladder, the liver, the heart, and then the salivary or spit glands here in the head and neck. But what's abnormal in this particular patient is along the lining of the lung here, he had a deposit of tumor, and also here in the abdomen, he had a deposit of tumor. So this is at the start of his treatment with high-dose MIBG and Irinotecan. 6 weeks later, after 1 course of that treatment, we saw this is his porticus, so that's actually not disease, that's just where his MIBG was injected for the scan. We see just a little tiny bit of disease here, and in the abdomen, that spot seems more or less gone or much reduced. And then he received a 2nd course of this MIBG and Irinotecan and had what we consider a complete remission, where we see no evidence of tumor here and no evidence of tumor here. So this is a very nice response in a patient with relapsed neuroblastoma. And our hope is that newly diagnosed patients may benefit from the addition of this type of therapy. So we have a planned COJI study incorporating a block of MIBG therapy into upfront therapy and not saving this very active drug for relapse or for patients who have refractory disease. So in this plan, patients will receive standard induction chemotherapy, and then they'll move on and receive a course of MIBG and Irinotecan. 2 weeks later, they'll get a stem cell boost, and that's because one of the main side effects of MIBG therapy is low blood counts. So they'll receive a stem cell boost to help them recover. This is not a transplant, it's just an outpatient boost to help them recover more quickly, so then they can move on about 4 weeks after that to their standard transplant. And then, once they recover from their transplant, received standard external beam radiation, not MIBG radiation, but more standard radiation. And our goal, this will be a smaller study, not a randomized study that will be available nationally. This will be open at about 20 to 30 hospitals. And really the goal of this first study will be to determine the safety of adding MIBG to frontline therapy and also the feasibility of this approach. And part of the feasibility of this is that MIBG has to be delivered in a specialized lead-lined room that's really only available at about 6 or 7 hospitals in the COJI right now. So we need to determine whether we can, in this initial study, safely and effectively get patients to their MIBG treatment center, get them to their transplant center for their stem cell boost and for their actual transplant. We're optimistic that this will be both tolerable, safe, and feasible, and if so, our plans call for a potential future randomized study where we really test now throughout the COJI in hundreds of patients whether adding a block of MIBG therapy helps to improve outcomes for children with high-risk neuroblastoma. So in our plans, we would have patients receive our standard induction therapy, and at the end of that induction be randomized either to standard transplant or to a block of MIBG, probably with Irinotecan, and then 6 weeks later their standard transplant and then radiation to follow. So this is our pilot study to look at feasibility. We hope will open within the next several months, and within a couple of years we should have results of that, and then hope to open this randomized study to really test whether MIBG improves outcomes for these patients. So what about minimal residual disease therapy, or what we call MRD therapy? This is the last phase of high-risk therapy, and the goal of this phase is to eliminate any last neuroblastoma tumor cells that might be hiding after earlier therapy. And our strategy for this phase of therapy is really to use completely different treatments or strategies than were used during either induction or consolidation, since we presume that any tumor cells that are remaining have resisted those initial strategies. So as Dr. Cohn alluded to, our MRD therapy in the Children's Oncology group has evolved over the last 3 decades. So in the 1980s, there was really no standard MRD therapy. In the 1990s, we learned about the importance of using accutane, also known as cis-retinoic acid. In the 2000s, we began to use accutane together with CH1418. And now we're really working on refinements to our new standard accutane together with CH1418. So I'll talk about each of these in a little bit more detail. So first, accutane, also known as cis-retinoic acid. This is a vitamin A derivative, and some of you may have heard of it as a drug for patients with severe acne. The main side effects of this oral drug are dry skin and dry lips, though there are some other less common side effects. And most importantly for neuroblastoma, in the lab, accutane has a very important property in that it turns neuroblastoma cells into more benign-looking nerve-type cells, or differentiates them from more malignant cancerous cells that can spread and cause trouble into more benign cells. So that's obviously a very favorable property, and is different from what we see with chemotherapy, where it just kills the tumor cells. So the Children's Oncology group completed a randomized clinical trial comparing after transplant either 6 months of accutane or no further therapy. And what this study showed was that patients randomized to receive accutane had fewer relapses or other significant events, so 54%, compared to patients who received no further therapy, 71%. So a significant reduction in relapse with the addition of 6 months of accutane therapy. And with that result, accutane for 6 months after transplant really became standard of care. Until a new drug came along called CH1418. So what is this drug? This is an antibody or an immune protein that is engineered to bind to something called GD2, which is just a substance that is present on almost all neuroblastoma tumor cells. This is an antibody that is partially made of mouse protein and partially made of human protein. That's where the CH comes from. It's chimeric. So a chimera is part one thing and part another, and this is part mouse, part human. And what we know is that when CH1418 binds to neuroblastoma tumor cells, sort of puts a little flag on the tumor cells and flags them for destruction by the body's own immune system. This is a drug that is given IV in our current regimen over 4 days in the hospital. And while we've seen that this is an effective drug, it is not without side effects. So some of the main side effects are pain. That's due to the fact that GD2 is also expressed on normal nerve cells. So patients have nerve-type pain when they receive this drug, typically just while they're in the hospital, not once they've gone home. Though our standard approach while patients are in the hospital receiving this drug is to have them on a pain pump or PCA to try to treat the pain. Patients also can develop fever, which is not typically due to infection, but just due to a reaction to the drug itself. Patients can also have allergic reactions, develop rash, and also can develop low blood pressure or leakiness, where some of the fluid that's supposed to stay in the blood vessels sort of leaks out into some of the other tissues and can cause some low blood pressure and puffiness. So with CH1418, in early studies, we saw that there was activity in patients who had relapsed neuroblastoma. In addition, some laboratory studies suggested that this drug seemed to be more active when it was combined with two helper medicines that are designed to boost the immune system. So two of those two helper medicines are called GM-CSF, which is a relative of G-CSF, which most of you probably have already heard of, and also a drug interleukin-2, also known as IL-2 or aldesleukin. So these two drugs don't have, aren't thought to necessarily kill the neuroblastoma tumor cells themselves, but they help the CH1418 work better. So the COJI conducted a randomized study of 6 months of accutane, which was at that time the standard, or 6 months of accutane overlapping with 5 months of CH1418. So this is how our standard immunotherapy calendar works. Patients in the first month receive CH1418 in the hospital, together with shots of GM-CSF, and also 2 weeks of accutane. In the second month, they receive the same therapy but a different helper drug, IL-2 or interleukin-2. Month 3 is the same as month 1, month 4 is the same as month 2, month 5 is the same as 1 and 3, and month 6 is just accutane alone. And we start this therapy, as Dr. Cohn mentioned, in patients where we think their patients are in a remission or very close to a remission, following transplant and following radiation therapy. Our current standard is that this treatment starts within 100 days of the last bone marrow transplant. So as we've heard, this clinical trial was stopped early since patients on the CH1418 arm were having fewer relapses or other significant events. So 34% of the patients treated with the antibody had events within 2 years of starting that treatment, compared with 54% of the patients treated with accutane alone. So now our current standard approach is to use obviously the better arm, CH1418, together with accutane. And with this approach and a single transplant, about 66% of patients with high-risk neuroblastoma are without relapse if they're able to complete transplant. So we know that unfortunately some patients will have a disease progression prior to getting to this point, or they'll have a bad toxicity and can't go on to receive this this therapy. But if neither of those things happen and a patient is able to get onto this type of therapy, we know that we've made a significant improvement in outcomes. So where are we going next with MRD therapy? Well, first, CH1418 is currently only available for patients enrolling on the COJI trial. For now, we have adequate supplies of the drug supplied by the National Cancer Institute, but that scenario is not tenable in the long term. So we're working hard to make make CH-1418 commercially available by helping a company that has licensed the drug seek FDA approval for this drug, which we now know is effective. And if the drug is commercially available, then you no longer need to enroll on a study to receive it. And also there's fewer concerns about potential loss of the supply of the drug. Some of the things that we're considering for our next studies to really refine this approach are to determine the optimum duration either of CH-1418 or of accutane. So 6 months of accutane was what was initially studied, but we don't know if 3 months is as good, if 9 months might be better, and so that may be one of the ways that we try to refine this regimen. Similarly, we used 5 months of immunotherapy, 5 months of CH-1418, but we don't know if more might be better or if less might be as effective. In addition, we believe that the addition of these helper drugs, the GM-CSF and IL-2, really do help. We believe that based on laboratory data, and there is an ongoing study in Europe that will actually address this very issue to determine whether the addition of these other drugs is actually necessary or whether they just add toxicity. In addition, we know that with antibody treatments, the more human the antibody looks, the less likely there will be allergic reactions or other allergic type symptoms from the drug. So we know that this drug, CH-1418, is partially mouse and partially human. We're looking at a humanized antibody without any mouse components that we might be able to substitute for CH-1418 and make this treatment potentially more tolerable. So we'll just spend a couple of minutes talking about the COJI trials for patients with relapsed disease. This is a list of our 3 most recent trials for patients with relapsed disease. First trial was of a drug called ABT-751. This is a drug that is an oral type chemotherapy. It works in a similar way to the drug vincristine, which is used in the upfront treatment of neuroblastoma. The COJI completed a phase 2 clinical trial of this drug in patients with relapsed neuroblastoma, and this approach did not seem to prolong the survival for patients with relapsed neuroblastoma. There were some hints that perhaps this drug was active in the relapse setting, and some patients are still receiving this drug on a compassionate basis based on some data that, for patients in remission, it may prolong time to second relapse. However, this drug is not FDA approved, and it's not clear that this drug will continue to be developed for neuroblastoma or for any other disease. So this may be a drug that no longer is available for anyone. The next trial was of a humanized 1418 anti-GD2 antibody that is linked together with IL-2, one of the helper drugs that helps to boost the immune system. So the goal of this is really twofold. One is to reduce the risk of allergic reactions when we use CH-1418, and the other goal was to provide the IL-2 helper drug together at the same time as the anti-GD2 antibody and in the same place, so to try to stimulate the immune system locally. The COJI completed a phase 2 trial of this new form of antibody therapy and showed a 21% response rate in patients without bulk tumors, so patients who had bone metastases at relapse or bone marrow relapses. The third trial was of a chemotherapy combination called irinotecan and temozolomide. This was a large phase 2 study. It treated about 50 patients with relapsed or refractory neuroblastoma. And this study, first and foremost, showed that this drug combination is very well tolerated in patients with advanced neuroblastoma. It showed a 15% response rate, and in addition, about half of patients, if they didn't respond, about half of patients had their disease remain stable. So it help to stop progression of the disease. So where are we going with upcoming trials for relapsed neuroblastoma in the COJI? Well, recognizing that irinotecan and temozolomide seems to be an active combination, and more importantly, a very tolerable combination, we think that we can use this as a backbone or a platform onto which we can add novel drugs. So we have planned a randomized study of that chemo combination together with one of 2 biologic drugs, one called temsirolimus, which inhibits a cell signaling pathway called the mTOR pathway that is thought to be important in driving the growth of neuroblastoma tumor cells, or in combination with a drug called bevacizumab or Avastin. This is another antibody that doesn't bind to neuroblastoma cells. It works by blocking the growth of blood vessels that supply tumors with nutrients. So this is a study that we hope to open early next year and determine whether adding either of these biological drugs to our chemotherapy backbone improves outcomes. And the goal really is to identify one of these combinations to move forward and to try to test in patients with newly diagnosed disease. In addition, we have a study plan for patients with relapse disease that will use this humanized 1418 linked to IL-2 together with GM-CSF. And we anticipate that this trial will open within the next few months. What about other options for relapse? So our committee, the COJI Neuroblastoma Committee, works very closely with the NANT Consortium, which completes more phase 1 trials of drugs like fenretinide and MIBG in combination with other drugs. And we'll be hearing more about this later from Dr. Mathey, who is the leader of the NANT Consortium. We also work closely with the COJI phase 1 Consortium, and this consortium has sponsored several trials that are of particular relevance for patients with relapsed neuroblastoma. One is of an Aurora A kinase inhibitor called MLN8237. This is a type of oral chemotherapy that in the laboratory has some of the most impressive activity against neuroblastoma. What we're trying to learn now is the laboratory is one thing, but people are quite another, and how does this drug seem to work in children with relapsed or refractory neuroblastoma? In addition, we heard from Dr. Cohen about the importance of the ALK gene mutation in neuroblastoma. Well, there is a newly developed drug that is an inhibitor of that ALK protein called crizotinib, or its drug name is PF02341066. And the COJI phase 1 consortium has an ongoing trial of this drug for patients who have neuroblastoma with demonstrated ALK mutation. And really the goal of all of these trials, while in addition to treating patients with relapsed neuroblastoma, our goal is to try to figure out which of these new novel drugs seem to be most promising to move into the upfront treatment of patients with high-risk neuroblastoma. So those are my slides, and thank you for your attention, and I'm happy to answer any questions. Thank you.
Anyone have any questions? Nope. Frank? Okay.
Do you have any idea why ABT 751 will be discontinued?
Well, what we see a lot in neuroblastoma, it's, as you all know, an orphan disease, and drug companies, unfortunately, don't have a ton of interest in orphan diseases because they don't make as much money as breast cancer, lung cancer, colon cancer, and so on. So we have developed other drugs in neuroblastoma that seem to have promising activity, but if they don't work in an adult type cancer, the drug company often abandons development. So I think that's been the case with ABT-751. That's not been a drug I've followed all that closely, but I think they had hoped that would have a clear indication, a clear path forward to FDA approval in an adult type cancer. And when that doesn't happen, we see this, that the drugs fall by the wayside, even if in our hearts we think they may be effective.
If the CH1418 is additionally humanized, how will that activate the immune response if it is more human-like? Yeah,
well, I think there's a couple of things about that. So there's two types of immune reactions related to antibodies. So when we instill a foreign protein into the bloodstream, the body's own immune system may recognize that protein as foreign and may actually kill the drug itself before it even gets to the neuroblastoma tumor cells. So that's sort of like an allergic type reaction where the body makes antibodies against the antibody, and that can inactivate the drug. So we think that the more humanized an antibody is, the less likely that will happen because it will look less foreign to the body. Then there's the good type of immune reaction that we want, and that's once the drug has bound to the neuroblastoma tumor cell, it stimulates the body's immune system to attack and kill that tumor cell. And we think that making the antibody more human won't affect that activity. We'll actually hear about this more from Dr. McGregor from St. Jude. Lots more about humanizing antibodies and why we think that's a good idea.
Thank you.
Yes.
My question was regarding the antibody study. And patients that receive the antibodies after the 2 or 3 year mark, does the survivor curve remain like 20% different, or does it move closer to the patients without the antibodies?
Yeah, it's a little bit early to say. Because I didn't include the survival curve in my slides, but actually maybe I'll steal Dr. Cohn's because she did. What's that? It's in mine. Yeah. So the curves look stable over. Oh, perfect. The curves look stable, but when you get further out, our statistical confidence falls off, and that's because. Oh, perfect. She's even got this. So you can see here at the start of the study, there were 113 patients in each arm. And over time, as patients either have a relapse or other event, or they get lost to follow-up, they move away, or other things, the number at risk, or the number that we know about, goes down. And as we get down here, if you look at the 4-year mark, we've only got 20 patients there and 12 patients there, so we need to follow these patients for more time. Now, that doesn't mean that only 20 patients made it to this point. Survived to this point. What it means is that a lot of the patients are still back here, and we're waiting for them to get more mature follow-up, we say, before we can have confidence that this spread is going to really be maintained, and to make sure that the curves don't come together and that we don't see that there's, that we've lost activity later on of the drug.
Okay, thank you.
Mm-hmm.
I have a question about.
You can ask me a question in San Francisco. This is one of our patients' mothers.
I don't get that much time with you. So the question is about second relapse. Do the second relapse treat the same way as the first relapse? For example, are they qualified for humans?
Yeah, our trials typically don't discriminate based on the number of relapses. So you either have relapsed neuroblastoma or you don't, and that's typically the entry criteria to get into COJI relapse trials or most of the NANT trials. For the planned randomized trial that I showed, looking at irinotecan, temozolomide together with biological drugs, that randomized study, that will be for patients just with first relapse, but for the most part, trials are written to allow patients with any relapse.
Okay, I have a second question. For treatments like MIBG or antibodies, it seems to me that when there's less amount of disease, it may be more effective. When you have bulk disease, it will be less effective, although MIBG treatment might be different. So it seems to me that early detection might be important in terms of how useful the antibody was. So who's doing research to improve the detection method?
Mm-hmm. Yes, we have a few things that we're working on. One, at UCSF, we're working on a type of MIBG PET scan where we might be able to detect disease potentially earlier. Another avenue of research is at the Children's Hospital of Los Angeles. They are looking at something that we'll hear about this afternoon called a TLDA assay, where we can do peripheral blood testing and look for low levels of neuroblastoma tumor cells in the peripheral blood or in the bone marrow to try to determine those things. So neither of those approaches are clinically available standard things. They're still research tests, but there is certainly research going on in that area.
Thank you.
Okay, we have another question here.
Thank you. Very enjoyable. I had a question about the relapse treatment of irinotecan and Temodor, or temozolomide. The most utilized version of that, are they both oral now? Are they still some IV? Or?
Yeah, so it's sort of hospital dependent. The Temodar is almost always given orally, although there is an IV preparation. The irinotecan started out as IV, and we have the most experience with IV irinotecan. Either given over 2 weeks or given over 1 week. More modern therapies and trials are looking more at a 1 week schedule, particularly in the COJI. The COJI phase 1 group and also the NANT have completed trials looking specifically at oral irinotecan, and it seems as though giving the drugs both orally seems to maintain the activity, and you can get enough blood levels of the irinotecan to maintain activity. So at this point, there's not a clear national standard. The COJI trial will use IV irinotecan, but there's also a relapsed COJI trial that is open for children with neuroblastoma and other types of solid tumors that uses oral irinotecan together with temozolomide. So it's more sort of dependent on which doctor you see, which hospital you're at, and what their experience is and what they're comfortable with. Some of it also depends on the patient, and we've had a patient recently who wouldn't tolerate the oral irinotecan because of the taste and actually preferred the IV. Many families obviously prefer an all oral regimen because they can get that at home instead of having to come into the clinic to do it.
Yeah. Thank you.
Okay, go ahead.
Sorry. When you were talking about the accutane being a 6-month as far as the treatment is now, are there studies going on now to see if 9 months or further treatment with accutane in conjunction with the antibodies is helpful?
No, there's not. We don't have an ongoing study of that. That's one of the options that we've been discussing, whether prolonging therapy with either accutane or with the antibody might be more effective, but there's not an open trial for that. We do, in the NANT group, we'll hear about a trial of accutane together with another drug that we think might make it work more effectively, but that's for patients with relapse disease, and that's ongoing therapy, not just 6 months of therapy.
So currently, when people are finished with the 6 months, they're suggested to stop? Is there anyone that says you should continue it on for a few months after, or?
I don't think that there's any literature or, you know, really good, really strong data to support that practice. Are people doing it? It wouldn't surprise me if people are doing that. It's a reasonably well-tolerated drug, and so, you know.
There aren't any guidelines for further?
No, the guideline is for 6 months.
Thanks.
That's the sort of national standard, yeah.